So let's switch gears for PRRT, or peptide receptor radionuclide therapy. And I know that you're looking for this part. So right now we're talking about two different timings of PRRT. The first time that you receive PRRT, I call it the first round. And for those who are not aware, typically the complete treatment of PRRT is 4 cycles every 8 weeks in between cycles. So to have a complete treatment, normally you do four cycles. Eventually, a patient might not tolerate to complete 4 cycles and less is done, sometimes 2, sometimes 3. Issues with the blood counts can be a barrier to completing treatments or to having to delay the treatments because your blood counts, meaning your white count or your platelets, might not have recovered from the prior round of treatments. So what we have for trials that look into PRRT, we have the ComPareNET trial, that's an alliance trial that look into doing PRRT with lutetium-177 or chemotherapy with capecitabine and temozolomide in patients with well-differentiated pancreatic neuroendocrine tumors that are advanced or metastatic. And why this trial is important is because, as I mentioned before, we have several options to treat patients, and we don't have a good sense of once patients progress or if patients have a lot of disease to begin with, what is the best course of action. In this case, particularly in pancreatic neuroendocrine tumors, where we know that capecitabine and temozolomide is very efficacious, thanks to the work from Dr. Coombs and colleagues from ECOG. We don't know, right? Because CAPTEM, we saw that might have a 40% response rate. And we don't know in a control setting up to recently, what is the response rate and progression-free survival of patients that receive PRRT for pancreatic NET. If you remember, the study that led to the approval of PRRT in the United States was done in small bowel midgut tumors. And that was extrapolated to all GI tumors, thankfully to many studies that have been done in a non-controlled fashion in Europe. So putting all that together, that led to the FDA to feel comfortable approving PRRT for all the GI well-differentiated GET-NABs. But we don't really know a lot of the response rates specifically on pNETs and PRRT. So that's a study that's going to look into that. This is also a study that if patients have a lot of disease to begin with and need a rapid response, they don't have to wait to have the disease grow after using a somatostatin analog. They can be considered right away. And there is few other eligibility criteria. So please, if your care team discuss this trial with you, consider participating, because actually my answer a very important question, because we always struggle to decide what's the best option for patients. And obviously, without good solid data, is a discussion with the patient, and obviously the patient has a say as well. I'm particularly invested in this trial. I'm the co-study chair, and Dr. Hopday from Mayo Clinic is the study chair. And this is a trial that's part of the National Clinical Trials Network, which is sponsored by the NCI. And I want to give a shout out to the NCI because they are really doing a lot to move the field forward, and they are extremely supportive of neuroendocrine tumors. So shout out to the NCI and the National Clinical Trials Network, along with the corporative groups that are part of that.